The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day to you. For me, it's another Tuesday morning, recording the next episode of TMD Demystified, and my name is Tony Urbanek. For the few of you who are not familiar with my podcast, I'm an oral and maxillofacial surgeon who trained at Vanderbilt, a medical degree at Vanderbilt, dental degree at Indiana, cell biology degrees at Indiana, fellow with the NIH for 2 years in facial growth and development. And in my private practice career, did over 2,000 temporomandibular joint surgical cases, basically half of them open joint surgeries through an incision in front of the ear of various types and varieties, and the other half through an arthroscope. I have lots of experience with surgery, and 14 years ago, I decided surgery was not going to be the answer because a third of the patients that I did surgery on would be back within a year or two with the same symptoms. And I did a research project of my own and actually discovered what was really going on with TMD. I discovered the actual pathological process, and that was a discovery that was already in the textbooks. It was already in the literature. The dots just need to be connected. And that's my claim, and we have proven that with in many different ways. We have a independent university study based on 3,000 successfully treated patients. But I am here to talk to you today on a topic that may seem kind of pedantic, but please let me explain. Today's title will be, what are nociceptors and why are they important to understanding TMD? For you doctors out there who took a histology course at some point in your career, you should know what a nociceptor is. And for the public who I understand view many of these episodes, a nociceptor is defined as a nerve ending of one kind or another that perceives pain. Nocere in Latin means pain. And you know, doctors have to speak in Latin terms to sound important. So instead of saying pain receptors, we say nociceptors. That's a fact. So we're going to talk about nociceptors. So nociceptors are cell types that are located in various portions throughout the body, both the external body, arms, legs, internal structures of some varieties, mucosa. So they be located in the mucosa of the stomach, mucosa intraorally. And they're also located, nociceptors, pain receptors, are located regarding the bone. They are located in the marrow of the bone, and they're located in what is called the periosteum of the bone, which is the covering of the bone, but not located in bone itself. And the periosteum, or covering of the bone, has a more than sufficient great number of nociceptors in them. If you are a dentist, you are well familiar with this phenomenon of nociceptors and how significant a response you get when they are stimulated. You can prove it to yourself every time you do a mandibular block, local anesthesia, through the mouth and to block the inferior alveolar nerve. when you place your needle through the mucosa, you get very little response because there are a lesser number of nociceptors in the mucosa than there are in the periosteum. So when you do your block, you take your syringe with a hopefully sharp needle on the end of it, and when you place it through the mucosa, you rarely get a patient's drawback or response. But if you go a little bit too far and that needle touches the periosteum on the medial aspect of the ramus of the mandible, that is when the patient will draw back. And that is a great example of the response of nociceptors. And it is a response of the mechanical response. There are different types of nociceptors that respond to chemical injury, pressure injury, different types of injury, but the nociceptors in the periosteum are more likely to respond to mechanical injury. And I think that is why they're called mechanoreceptors. But anyway, a nociceptor is very, very interesting to fully understand TMD. So let me explain. I will try to be simple and I'll try to be very direct. Let me first of all make a review of what's really going on, what really is the pathological tract of the symptoms of TMD. Again, for review, the symptoms of TMD include, and no one disagrees with this comment, the symptoms of TMD, and you don't have to have all the symptoms, but most people have many of them: frequent or recurring headache, earache, jaw pain, neck pain; tinnitus, ringing in the ears; subjective hearing loss, a feeling of fullness in the ears like you've been swimming and can't clear your ear; dizziness, vertigo; upper back and shoulder pain and tightness or tightness; arm, hand, finger tingling or numbness; and various kinds of jaw locking. Those are the well-accepted symptoms of TMD, which are very disparate symptoms, and they can occur in one patient. In fact, we frequently see all of those patients in all of those symptoms in a single patient. And for our medical colleagues, my medical colleagues, and the patient comes in with various symptoms on that list, medical doctor just says, "You must be crazy." And most dentists don't want anything to do with TMD because they don't understand it, or they don't understand it and prescribe a night guard and hope the patient doesn't come back. But the point is, those are the symptoms of TMD, and how do those symptoms originate from some kind of damage to the temporomandibular joint? Well, damage to the temporomandibular joint, the common denominator to damage of any kind is inflammation. When the body in any way, shape, or form becomes damaged, the immediate response is inflammation. If the inflammation doesn't go on a routine basis to full and complete healing, it is called chronic inflammation. And that is exactly what you see in each and every patient who has TMD, temporomandibular joint disorder. They develop sooner or later chronic inflammation within the temporomandibular joint. How do I know that? I know that because after 2,000 temporomandibular joint surgical cases, each and every one of those cases, a piece of tissue was sent to the pathologist. That is standard operating procedure in any operating room. A piece of tissue is taken from the surgical site and sent to the operating room for review. And in each of those 2,000 cases, the pathologic path review returned as line 1, chronic inflammation, or description of the cell types that were equal to chronic inflammation, no matter what else that pathology report included. First line was always chronic inflammation. So after 2,000 cases, without exception, you can deduce that if you have TMD, you have chronic inflammation within the temporomandibular joint. So what happens when the temporomandibular joint is inflamed? Well, those were the dots that were connected. It's in the literature. The autonomic nervous system plays an extremely important part in this. When a joint, whether it be elbow, hip, knee, or temporomandibular joint, becomes chronically inflamed, it sends a signal to the brain that says, "I'm inflamed." The brain modulates that signal in an attempt to help healing, sends a signal back down to the muscles that move that joint, in this case, temporomandibular joint, that says, don't move the joint. Tighten the muscles that move the joint. Tighten up. Constrict the muscles. Don't move that joint, in an attempt to help healing. And when those signals come down, and they always don't come down to the same muscles at the same time, they come down to various muscles, different muscles over time. It first comes down to the muscles that move the jaw. There are 5 major muscles that move the jaw. Our dental friends know the names of those. Hopefully you do. And the patients complain of different various pains around the face and oral cavity, and they will point generally to the point where the muscles getting the signal to get tight attach to the bone. Hopefully you see where I'm going with this. The muscles get signals to tighten up, to constrict, and where those muscles attached to the bone, even either the origin of the muscle or the insertion of the muscle, they pull on the periosteum and stimulate the nociceptors. They stimulate the nociceptors. And when the nociceptors are stimulated by the excess and continuous pulling on the periosteum by the muscles, it will create pain, and patients will complain of various pains in various areas of the face, origin insertion of the muscles of mastication. When the chronic inflammation doesn't subside, the pain is ignored, or you go to a provider that does something that doesn't work, or isn't significant in the treatment of TMD. Best example I can think of is Botox. Frankly, I will say openly, Botox is a scam. And topic isn't Botox today, which is botulinum toxin A. The generic is botulinum toxin A. There are other brand names for botulinum toxin A. Botox is just the most well-known. Everyone refers to botulinum toxin A as Botox. Everyone in the country uses Botox if they're going to use botulinum toxin A as the name of it, although there are several other names. But there is a recent article, I pulled it out just recently, and we're not going to talk about Botox, but this is an article from the Journal of Oral and Maxillofacial Surgery, extremely well done article. I've noted it before, but I give it to you as an example of trying to treat symptoms of TMD without treating the cause. And this is a good example of trying to treat a symptoms. Yes, if you paralyze a muscle that has been given the signal to tighten up, it won't pull on the bone and therefore will not stimulate the nociceptors. However, the signals move around to other muscles. So you're basically chasing the signals, the nervous signals, to various muscles. So sometimes it'll hurt here at the insertion of the masseter muscle, or it can hurt here at the insertion of the temporalis muscle, or it can hurt here at the insertion of the mylohyoid muscle, or the medial lateral pterygoids, where patients will always complain of pain right in their doctor, but they don't always complain of pain there. It can move around. So if you use Botox, botulinum toxin A, and paralyze this muscle, what about tomorrow when it hurts over here? You're basically just chasing the symptoms. As noted on previous episodes, I've talked about a patient I had who she and her insurance company spent over $200,000 on Botox over 10 years, and she finally was sitting in my office, in my chair, examination chair, to get an actual significant permanent relief from her symptoms by attacking the chronic inflammation, which is in the temporomandibular joint. Decreasing chronic inflammation adequately will decrease all of the symptoms, not just painful symptoms. It will also decrease tinnitus, subjective hearing loss, and vertigo, because the inflammation creates the nervous signal that stimulates the muscles. And in the case of tinnitus, subjective hearing loss, and vertigo, decreases inflammation within the joint, which no longer forces inflammatory fluid through the petrotympanic fissure into the middle ear. In any case, botulinum toxin A, better known as Botox, this article, which I want to give you the reference on, basically extremely well put together article, statistically proves that whether you use saline or whether you use Botox, you get the same result by injecting it into muscle. This was based on the masseter muscle. And the conclusion is, I will read it to you, Botox A, Botox A and saline placebo injections both decrease pain in the subjective MPD myofascial pain disorder, which is basically TMD. And this article is in the April 2024 volume 82, number 4 of the Journal of Oral and Maxillofacial Surgery. So whether you use saline, placebo, or Botox, you get the same results. So save your money on, if you want to do it, save your money on the Botox, just inject saline. That's what this article proves scientifically. All right, getting back to nociceptors. So you can see that nociceptors are the result of muscle pulling on the bone. And when the inflammation is not decreased adequately or ignored or treated with various treatments that only treat symptoms like botulinum toxin A or microneedling or drugs of various kinds that do nothing but suppress the nervous system along with all its side effects and sometimes dangerous side effects, the result can be very negative for the patient. But when the inflammation is ignored adequately, the signals come down, don't move the jaw. Now I want you to move the head tight. Tighten the muscles that move the head, and the neck muscles become tight. And the second most common symptom of TMD, temporomandibular joint disorder, is neck pain, and patients will complain of pain across the back of the neck and the insertion of the sternocleidomastoid, and that is a very common symptom of TMD. Actually, the second most common symptom of TMD is neck pain. And when it goes beyond that, the signals come out to tighten the upper shoulder girdle, the muscles of the upper shoulder, and patients will complain of upper back, not lower back, upper back and shoulder pain and tightness. And when these muscles on the side of the neck get tight, they're called scalene muscles or strap muscles in the vernacular. When they get tight, they're little finger muscles on the side of the neck, and through those finger muscles, scalene muscles, come the brachial plexus, and when the brachial plexus gets squeezed by those muscles, it creates arm, hand, finger tingling and numbness, which magically goes away when the inflammation in the temporomandibular joint goes away. It's absolutely phenomenal when you actually track how inflammation within the temporomandibular joint creates all these symptoms. And a very important part of tracking how it all works is the nociceptor, which is located in the periosteum of all of the bones of the upper shoulder girdle, of the neck, and the face. When you make the inflammation go away, all the symptoms go away. And the best way to make inflammation in a damaged joint go away, the simplest way, the least expensive way actually, is to rest the joint. Rest the joint adequately. That is how tennis elbow is treated. My orthopedic colleagues identified for me the better part of 50 years ago, tennis elbow, which uses this exact same mechanism. Tennis elbow is inflammation of the lateral epicondyle of the elbow, lateral epicondyle, because of too much motion of the forearm. Repetitive motion of the forearm will create inflammation in this joint. An autonomic signal is sent up to the brain that says, I'm inflamed. The brain takes that signal, modulates it, and says, I'm going to help you. Don't move the joint, sends an autonomic signal back out through the sympathetic portion of the autonomic nervous system to tighten the muscles of the forearm. And patients don't complain of pain in the elbow. They complain of pain in the forearm all the way down to the wrist, where the muscles of the forearm attach to the bone and stimulate the nociceptors of the bones of the forearm. This same mechanism is the exact same mechanism that runs TMD. TMD and tennis elbow is the same disease, different joints. Let me repeat that. Tennis elbow and TMD is the same disease, different joints. Unfortunately, dentists haven't read the literature because the orthopedic surgeons know all about this. If the orthopedic surgeons had been left to treat this joint, of course, they treat all the other joints of the body except the temporomandibular joint. That was left to my dental colleagues. Why? Because this joint is attached to the jawbone, which is attached to teeth. And orthopedic surgeons don't want anything to do with teeth. That must be a dental problem. So it was left to the dentist to figure it out. But they didn't figure it out. They want to treat symptoms. They want to use Botox. Listen, the reason I'm kind of drilling down on Botox today, because just yesterday I had a discussion with a very awake young lady who told me, I did not bring it out of her, I did not start the discussion. She said she had been offered Botox by her dentist, and her opinion was she thought that there was something wrong because now every dentist that she knows has been wanting to use Botox or botulinum toxin A, if you want to use the generic, for her TMD problems. And she thought that it was just an effort to make money. And those were her words, not mine. I think you can deduce what my opinion is about it also. In any case, treating symptoms, you can chase symptoms forever. But if you actually decrease inflammation, and the best way to decrease inflammation in the temporomandibular joint, as it is in tennis elbow, you put the arm in a sling until the chronic inflammation dies down, and the symptom of pain in the forearm will go away. If you put the temporomandibular joint, we don't have slings for the temporomandibular joint, but we have devices that unload the joint by separating the posterior teeth, where all of the loads on the temporomandibular joint, or 90% of the loads on the temporomandibular joint, are from the back teeth, the posterior teeth. So you have a device and protocol because you have to learn how to use it. It is a tool. There's nothing magical about this tool. There's some nuances that you have to know how to use the tool. That is why you have to get a dentist involved. You don't sell this on the internet. You have to have a dentist who makes sure that you use it correctly and you don't create problems for yourself by using it incorrectly. But if you separate the posterior teeth adequately, the inflammation will die down, just like the inflammation in the lateral epicondyle dies down. The signals to the nociceptors stop. The muscles quit pulling on the bone, creating pain. And in the example of TMD, temporomandibular joint disorder, the painful symptoms go away. That is how it works, and it's very simple. It is not complicated. I've always thought I don't understand why it took the better part of 70 years to figure this out. I take pride in it, but I don't feel good about it. I don't feel happy that my dental colleagues are doing things that are not successful. In my case, I determined after way too much time, actually, 36 years of operating the temporomandibular joint, that was not the right way to go. But eventually, I did take an independent investigation of it and figured out what the actual method is to create all these disparate pains. which we call TMD, temporomandibular joint disorder, and most everybody refers to it as TMJ. And to remind you, we have two of those. Everybody's got two TMJs. So I hope this has cleared up. Hopefully this has cleared up for the majority of you watching. There are going to be some contentious folks out there who want to defend using botulinum toxin A or other modalities, especially drugs, that can hide symptoms, can cover up symptoms, along with creating a lot of other, sometimes very serious side effects, but are not effective in the long term. Long term, using a device that you use 24/7 for 2 months, then nighttime only the rest of your life, will bring that inflammation down and keep it down adequately where you don't get the signals to tighten the muscles, and the symptoms, painful symptoms and non-painful symptoms of TMD will diminish and go away if you use the device correctly according to the protocol. So hopefully now you know what nociceptors are and why they are so important to understanding TMD. With that said, we'll move on. Look forward to the next time you tune in to the next episode of TMD Demystified. I'll pick another topic, hopefully, that'll be relevant for your understanding of this, what most people think is a complicated problem, which is not. It is not complicated when you understand the pathology involved and a little bit of histology, a little bit of anatomy, and a little bit of common sense. It boils down to TMD Demystified. I am Tony Urbanek.